the responsibility of talking about what is the history of gender affirming healthcare in South Africa. So I want to make a disclaimer that what I'm going to be talking about is really my perspective in the way that I see things, right? And so you ask yourself, why is it important to listen to my perspective? Let me give you a couple of things to think about. Number one is that I am a multiracial trans woman who grew up in Transkei, during the apartheid regime, and this was the former homeland. And why are these things important? These things are important because these are the determinants that shape the kind of access that people have to gender affirming healthcare. Now, I grew up in the 80s, and I grew up in an area where folks of color didn't even have access to the local library. So all you really have is this feeling of who I am. There's no name for it, there's no label, there's no definition. It wasn't until late 1996 that I once got hold of a magazine and I read an article on somebody who had undergone gender affirmation surgery. And at the time, it was referred to as a sex change operation, whatever that might mean. So in later years, in 1999, I moved to Cape Town and I met the first transgender person at the Triangle Project. So there have been, the issue of gender affirming healthcare has been on the table. It's been something we've been talking about. It's not a new issue. So if you have the opportunity, please go and read on the Aversion Project. So the Aversion Project is one in which gay men in the military were found to be transgressing norms. And, so the government at the time decided that if somebody wants to be gay, why not just become a woman? And so all of these, especially feminine gay men, were subject to, and this is in the 1970s, they were subjected to what is now called torture, which I firmly believe because, these operations were done involuntarily. And these operations were done, some of them were done halfway, some of them were given hormones, it was just a terrible human rights violation. Why am I telling you this? I'm telling you this because for me, it's quite ironic that 30 years, 40 years later, we are still having these conversations about lack of access to care when in the 1970s, they subjected people to involuntary gender reassignment operations. The other point that I'm going to make is that I recently went to the Women Now conference, which was a pre-conference to ICASA in Durban. And there was a speaker who talked about the forced sterilization of women living with HIV. So one of the things that we constantly run into as we are seeking gender reassignment surgeries, we are being told that there isn't enough resources, there isn't enough theater time. So my feeling about it, and as I was sitting listening to the speaker, I was thinking to myself that there is enough resources to involuntarily sterilize women, infringe on their reproduction, in the same breath you are saying that there isn't enough theater time to be doing, let's say, for example, transgender men who want to have the reproductive system removed. And this is something for us to think very critically, because the other issue is that we need to see what are the intersectional struggles. And I started framing my talk around living as a gender non-conforming person in rural Transkei. Not much has changed for gender affirming folks in those areas. The healthcare package hasn't changed much. So coming back to my story, in 1999, I first met the first trans person. In 2001, which was my first year at university, I was then put on this list at Grote Scale. I am still on that list. It is now almost 21 years later. So the history, if you look at our history throughout the years of pushing forward transgender people and fighting for access to care, one can immediately see the theme of the theme of resources, and one can also immediately pick up on the theme of power and who gets to make these decisions. That said, 2001 has come and gone, 2002, 2003, 2004, and 5. 2006, I started going to the clinic, the gender reassignment clinic at Steve Biko Academic. It is there where I met somebody called Tina West, and Tina West introduced me to Gender Dynamics, and Gender Dynamics was formed in 2005. So I've been in the struggle a really long time. So when I met Tina, at the time we were told by Steve Biko Academic Hospital that if we didn't engage this private provider, Dr. Colin at the time, we were not going to be seen at a government clinic. So we went to government clinic, and yet we were expected to be engaging a private provider. Mind you, at the time, to see Dr. Colin, it cost about $1,000 and something just for the consultation, just to be able to see Dr. Colin. Again, I draw intersectionality into this, because somebody who's paying R1,000 to a session to see a psychiatrist who's going to gatekeep and see and say, you either are or are not going to be allowed into the program. That for me was terribly triggering, because number one, it was out of reach for me. I stay in the Eastern Cape province, where our health system is so poor that at times we cannot even do diabetic amputation. So one, that's the context of it. The other is that as a person of color who don't have access to money, who are discriminated in employment, that's the other layer for me, is that how do we make sure we put this within reach of folks? We've come a long way in terms of strengthening the healthcare system response toward transgender people. In 2011, we had a pre-conference which was held at Hout Bay. And that is the first time we started seeing people come into the room, at least people who were in designated health government departments, such as the Department of Health. But at the time, we still hadn't seen the intersectionality of how health issues intersect with issues such as the economy, and, for example, legal gender recognition. In the 2012 and 2014 conferences of Gender Dynamics, we've really started seeing the momentum, because we now also had people who became interested in developing research, because the importance of research is that one must bear in mind that these are eventually formulated as policy recommendations and pushed forward. Where it became strategic for me was around the engagement of trans people in HIV care. In 2010, a small group of trans people from South and East Africa met in Namibia. It was around the time when this language was introduced around men having sex with men and women having sex with women, WSW, and how that intersect with HIV vulnerability. So the policymakers and the funders at the time had the view that gay men and trans women and, gay men and other MSM and trans women were all being made vulnerable simply by having anal sex. And then we came up with a position paper to say that, no, this is not quite how it's gonna go, because if you expect me as a trans woman to go and engage in an MSM forum, it means, number one, you're not recognizing my gender identity. And number two, that you run the risk of me not being fully engaged in healthcare, a phenomenon that we're still seeing amongst trans people, by the way. So we came up with that position to say that trans people need to be engaged as a key population within the HIV discourse. Now, of course, we didn't have any evidence to back this up, and so we relied on the international literature that has started showing that trans women are particularly vulnerable to HIV infection. So this was a point that we brought into the discussions when we had the 2012 strategic plan for the country on HIV, TB, and STIs. So we then got a mention of trans people in the plan. So now that we had a mention, we then had to think about, okay, we're being mentioned and we are being listed as a key population. What does that mean? We don't have a program that goes with it. But soon enough, there were calls out from Global Fund Prime recipients, and we responded to that call. And the first call for HIV work was really around it was really about LGBT populations. So we first applied through Right to Care, and we were successful in that round. The later call for proposals after we had finished those 3 years, then was request for proposals working on MSM TG. But we continue to champion this idea that even within LGBT, please recognize that there are intersectionalities, but there also are unique vulnerabilities within each of these groups. So once that call had come out, we then had an idea of, we then applied, but with the idea that we still need to champion to take transgender out of the shadows of MSM and sex work, because this has always been the case that transgender people, for the sake of convenience on policymakers and implementers, let us fit transgender people under these key populations. And suffice to say that, our unique healthcare issues have been obscured by having been inserted, under these packages of care. So when the next strategic plan came out in 2017, we continued to have transgender people in there, and the call from the funders had also then been more, had been separated, as in having a funding stream for MSM and having a funding stream for TG. And now, why I want to talk about why I'm talking about the issue of HIV is that we've seen through the years, I've been on that list at Grotesque since 2001, and we've seen that this is not an issue that is really being prioritized by government, policymakers, and implementers, right? The issue of gender affirming care. Now we can see from the international literature that transgender people are incentivized or are motivated to take good care of ourselves if HIV program is packaged in a way that is also giving gender affirmative services. So this is an argument that I've used in the development of the strategic plan focused specifically on LGBTI. And here's where I must commend Senec, because in the development of that strategy and the development of that plan, there was a sincerity about at least costing. Let's see how much this is going to cost. How much, if we provide an HIV package and if we provide PrEP and PEP and ART, if we add hormones to that package, how much will that be? How much will it be in addition to a surgical package? Of course, in the negotiations, due to the cost, the time, the other resources, the issue of surgeries had fallen out of the plan. However, we now know that we know that when HIV programming comes to transgender people, we know that something that is an essential part of that program is to make sure that there is gender affirming care. But of course, all of these things look very nice on paper, very good ideology, very inclusive, but how does this translate into the lived realities of people on the ground, right? That is what we need to get right. I've taken you through this historical lens, and I'm now talking about what is it in concrete, tangible terms that we want to achieve and that we want to see, that we want to have realized. We've seen the commitment on the part of government. We see implementers coming and going in our provinces. The question we need to ask ourselves is, what has been shifted for the trans communities, wherever you are in your community, whether that's in the Free State, in the rural Western Cape, in Limpopo, wherever you might be, the question you should ask yourself, like, with all these policy commitments and the commitments to make sure that this population that is so vulnerable to HIV, violence, and other social ills, what is it that we need in order to take these conversations forward? For me, it always feels like very bittersweet, because I talk about some of the gains over the years, and there's been significant gains. But then I engage with somebody from Tabanshu in the Free State, and they say, at our local clinic, I'm not even being given hormones. And so this is something that we need to think about and think about very deeply, because we have this big public health institutions where the funding sits. In these institutions, based on the priorities that is set at the national agenda, how do we engage with these institutions? And the last point that I'm going to make is around, who does the money sit with? Are we as civil society, are we getting our fair slice of the pie? Are we getting our fair share as activists who have championed for funding from the Global Fund and funding from USAID PEPFAR? Where does that money sit? That is another question that I want us to ponder on as we are heading in our conversation today. And it's not just for me about the money, it's about making sure that there's equitable distribution of resources to do this all important work. I'm going to be on the call for another 10 minutes, in which I'm going to take questions and comments from the audience, but I'm going to stop now to engage with people of the conference. And if I drop off the call, I want to wish you a good conference for the rest of the day.
Thank you. Thank you, Leigh. Thank you so much, Leigh. Questions? Any? Okay, thank you. Okay.
It's Aurora again. My biggest question is, how do we go about getting surgery? Because the waiting list is a bit too long and it takes like ages and ages and ages, which makes us go out and do a lot of things that we are trying to run away from. Like, we are being forced to go out and date these older guys who can actually support us with money and who can actually give us this thing of hope that I'll give you money to go and do the surgery. In the meantime, there's no man or there's no guy who can give you that kind of money or support you in your whole things, like the transitioning thing, without having sex with you, without any protection. So how do we go about, do we get anything, any like promise from our government that, let's say within 5 years, this is what we can do, or within 7 years, this is what we are promising we can do for you. As a trans woman, I've been on hormones for like close to 4 or 5 years. So I think up to so far, I'm not happy with the way things are going, with the surgery thing, because they say to you in the first 2 years that you are eligible to go for your surgery. But up to so far, I haven't gotten anything. It's just promise after promise, which makes us do all those things. So I just wonder what is it gonna take to help us get where we want, the information that we need. Thank you.
Are we taking more questions or should I respond?
Please respond, Leah.
Please respond.
Thank you so much. Thank you for your question. Really, really important question. And I think you should be addressing the question to your local government, right? What does the health department in the Free State say about access to surgeries? And I keep saying this to policymakers and to implementers, is that the issue of surgeries is not just about having a surgery, it's about a life-saving
Are we experiencing technical difficulties?
intervention for somebody to get into very dangerous, relevant, appropriate economic. Sorry, can you hear me?
Yes, now we can hear
Hello?
you.
Okay, great. Apologies.
She's losing her signal.
Yeah.
Really one that should be put to our asking folks in the issue. Hello?
Yes, it's better now. You can speak.
Okay, great. Also, the other issue is about what does your local HIV council, the AIDS council, civil society, where do you champion your issues? I'm sorry that I'm not giving you any concrete answers. You and me are in the same boat, but I'm raising points about who should we engage and how should we engage the stakeholders. The first point of call should be your local civil society. How do you engage with civil society? How are your issues brought to the table? The local LGBT sector within your AIDS council, what is their position on the issue that you are raising? I'm raising more questions than answers, and I'm hoping that this is food for thought.
Thank you. Any other questions? Thank you, James. Hello again. My name is Kingley. I understand about that we are in the same boat as now, but the fact that she has been in the field for such a long time and understood the situation from a young age today. The list has been there years and years ago, and we are not sure whether it's working. But answer from the group say, what is the AIDS Council saying about AIDS? What is the section of the HIV in the free state saying about AIDS? And if there is a possibility, as much as they understand that we as a trans community, we are vulnerable when coming to HIV, why can't they be a way of making things easier for us? It's very frightening to go to a clinic to get your medication, and tomorrow you go to university to get your hormones. Why can't you get everything in one package as well? As much as if I had TB, I have to stop taking ARVs and treat my TB at a rate in clinic. How is that? Why is it even that possible for us? Thank you.
Can somebody repeat the question for me?
I'm saying that I understand that you and I, we are in the same boat. But for my side, that I am from the Free State, I've seen that the Eastern Cape, with the help of you and the energy chapter for that side, things are more smoother than that side. Is there a possibility for our Free State AIDS Council and the LGBTI sector to make things easier as they are in your side, in the Eastern Cape? If there is a way of adapting whatever you're doing that side to that side, I would like you to just to add on what I'm saying. If there is a possibility that you guys can have on this side. Thank you.
Did you hear that, Leigh?
So if I got it right, it was very difficult to hear, but if I got it right, the question is that in the Eastern Cape, we've managed to achieve certain things, and what can be done to ensure that trans people are engaged, or what can the Free State AIDS Council, LGBT sector learn from other provinces? Did I get that right?
Yes.
Did I get it right? Okay.
Yes.
Right. So I think, first of all, just because there's been a trans organization here that have been championing these rights for over 11 years. And I'll tell you something, Kim, is that the more you work with decision makers, the more they seem adverse to your message. But I think what has been successful is for us to be in those rooms where the decisions are made, where the conversations are had, to keep showing up. And when they say MSM, LGBTI, we constantly add our message to say, and trans people. And trans people. It may seem insignificant, but if you attend your World AIDS Day, for example, go to those spaces and talk about trans issues. If you attend conferences around the Department of Justice, go to those spaces and keep reminding them that as trans people, we are still here. We are still needing services, and this is exactly what we need. So I think one of the things that have work well for us is trying that strategy of being visible in spaces, going into spaces, making sure that we remind them we are still here and we still need these services. The Eastern Cape is by no means perfect. I do think there's more room for engagement. We can do that, but the more we are not engaged in these spaces, the more our issues will not be heard.
Okay, thank you. Any other question?
I have a question for you, Leanne. Hi, Leanne.
Hi.
Thank you for joining us. We're excited to have you. I have a question that I would like the room to know about you. You have, as an individual, done some innovative work and some groundbreaking work to have us here as an organization that implements the transgender program. Please tell us about some of the advocacy you did directly overseas and what it took for you to get the message across and how you insisted in some of the stunts people. I'd love to hear some of those things.
So thank you so much. No pressure, no fun. So for me, I think people describe me as radical. So last week we were at a conference in Durban, the Women's Pre-Conference, and we had a specific session on research. So CAPRISA came as one of the big research bodies in the country, and we spoke about like, how do we see research? And I'm teasing out this very specific example, right? I think one of the strategies is to think about the power that we have, right? And I get irked by messaging that talks about the voice of the voiceless, because nobody is voiceless. I really get irritated by that kind of language, like the voice of the voices and the empowerment, right? That donors bring or international researchers bring. Because if you think about it very carefully, is that if a researcher comes up to you and says, Nosana, I would like to interview you to feature in my research. Nobody's like, who's empowering who in that kind of context? It's really you that's empowering the researcher, because without your story, what does the researcher have to tell, right? Similarly, the issues around funding, it's like donors don't just give money for the sake of giving. They have a mandate that they have to fulfill. And if you realize your worth as an organization, to say that we contribute to the healthcare system in this particular way, that is also an empowering experience, right? Because it goes both ways. And so one of the advocacy strategies for me is around interrogating language, because language is never innocent. Language is not innocent. What we say has implications. And that's always a very scary thing for me. It's like when we do our advocacy, how do we package those meanings? For example, this one time before the days when we had HIV prevalence data among transgender women, a donor once asked me, so how do you know that you have a problem with HIV among transgender women? I said to him, look at me, I'm overweight. I became fat from funeral food because I was attending funerals of sisters and daughters and being a pallbearer. And that's how I know, because I went to the grave so many times. That's how I know that we have this issue among transgender women. But now you need to invest in a scientific methodology so that we can get the data that is captured through this scientific methodology in order for us to make sure that this is an issue that is put on the table as an advocacy point so that we can have just and equitable resources to address the HIV burden in our community.
Thank you so much, Leanne. But I also wanted you to mention what you actually sat and did overseas and insisted some of the international funders that we have, you know, and how you influence the national strategic plan, as well as have been a key player in having the transgender community recognized as a key population.
Yes, of course, and that brings me back to the point what Kim was saying, which is around visibility in those spaces. Look, the decisions will get made whether you are there or not. So you best be there because your life is being talked about. So the visibility, one of the advocacy strategies is around visibility, right? The visibility in the epidemiology, the visibility in the data, how we exist. And we also, another advocacy strategy is for us to also immerse ourselves in the data, folks. I know it sounds very white and it sounds very academic, but when policymakers talk about us, they cite these data sources. So as people who do advocacy, we must be well versed in that data because that is a reflection of our lives. And whether or not we are around the table, some decisions will be made based on our lives. I've been fortunate to be part of the technical working group, which has I've certainly pushed advocacy within that forum. I've been part of a few of the strategic planning meetings in order for us to develop our strategy. I've been part of consultations with Global Fund and USAID, PEPFAR, and it's always really important to be in those spaces because that is where packages are shaped, where funding is available for to do this very important work as transgender people.
Well, thank you so much. Thank you so much, Leigh, for sharing the story and for inspiring us and giving us exactly what our key role is. That we can't sit alone in our corners or only sit as organizations. We have to go to the bigger platforms, the municipality, the civil society, the LGBTI sector. We need to go to World AIDS Day events and say, hello, I'm trans, I'm here. But you know exactly what I would like. So thank you so much for that. Thank you.
She gone?
No, she's here.
Okay, she's still here. Okay, thank you, Leigh. Because we are live streaming, my beautiful people, it's steady when you are up and down. Please let's try and minimize movement as much as we can. And it steps other people. Thank you. Let me introduce to you our first speaker, Dr. Anastasia Thompson. She will be speaking about transgender healthcare and HRT. Welcome, Dr. Anastasia. Hello, Dr.
Hi. Hi, good morning. Are you able to hear me clearly?
Yes. We can hear you.
Fantastic. All right, excellent. Thank you so much. Time is short, so I will try to not waste any. Just by way of a brief introduction, my name is Anastasia. My pronouns are she and her. I'm a medical doctor, an author, and an activist, and really with a focus on human rights, LGBTQIA+ rights in particular, and access to healthcare for transgender people and this community that I am part of. I'm going to, so the topic that I've been asked to address you on today, and I'll just start by saying that it is a great privilege to be here. I'm not sure exactly who is in the room because I can't see you all, but I do know that I'm talking to people who are intimately involved in the provision of vital healthcare services. And the subject that I've been asked to address you on today is indeed healthcare and gender-affirming hormone treatment for the transgender community. In order to understand really what the concept of healthcare encompasses, it becomes essential to adopt a view that is holistic and that is understanding and cognizant of not just the healthcare system, but all of the systems around it. So very often when we have the discussion around healthcare for transgender people, it tends to center very largely around concepts of hormone therapy and surgery. And don't get me wrong, these two components are vital, certainly for the well-being of many people in the trans community, certainly not all of them, but for a decent proportion of people in the trans community, really a big point of concern is access to hormone therapy and access to surgery. And I'm not suggesting that these are not important, but rather what I am saying to you this morning is just that if we're gonna address healthcare through the lens of the trans community, we have to take a much broader view and a much more expansive understanding of what healthcare encompasses. And for so many people in the trans community who face discrimination and marginalization on the basis of their identity, even access to basic services becomes a tremendous challenge. And when I talk about this, I'm talking certainly about healthcare. I'm also talking about issues that affect legal documentation, home affairs, access to education, safe housing, social support, etc. All of these are made so much more difficult when someone is part of the trans community, and especially if there are barriers in terms of legal documentation, if your ID document doesn't line up with who you are. So we have to begin to contemplate the journey of the transgender person in accessing any form of healthcare from beginning to end. And that means that it starts at that person's place of residence, if they have one. Many in the community are homeless. We also know that there's a refugee community of which many members are transgender in South Africa who face discrimination along another intersection, namely xenophobia. So it starts at that place of shelter or residence with the journey to a point of care where someone can begin to access healthcare services. Along the way, that person faces profound challenges. Transport can be prohibitively expensive. Healthcare services, clinics and hospitals can be far away. If you do make it to the healthcare facility, you will be forced to identify yourself, to take out a file or to open a file, to sit in a crowded waiting room full of people and possibly be called into a consultation under a dead name or to be misgendered in that space, potentially disclosing without your consent towards a room full of people that you are in fact trans, or that there's something different about you, and potentially making you a target for further acts of violence, whether on a micro level or a macro level. We know that access to basic healthcare is a profound challenge, and there are reports from around the world, perhaps not as well documented in South Africa, but that shouldn't lead us to mistakenly think that incidents like this do not occur within our own borders, where people have been involved in, for example, a motor vehicle or a pedestrian vehicle accident, and the emergency medical technicians who arrive at the scene upon finding out that a person is trans, usually because they're removing clothes and they see parts of this person's anatomy that in their estimation do not line up with what they were expecting, people have been left to bleed out in the street, literally to bleed to death under the watch of those charged with rendering life-saving emergency medical treatment. If you have to get access to treatment for HIV, which we know affects marginalized groups disproportionate to the rate at which it affects people in the general population. if you have to get treatment for tuberculosis, for bronchitis, for COVID, for high blood pressure, for diabetes, you might be subject to discrimination from the healthcare provider upon the point that they understand that you are transgender, and often you'll be forced to disclose this or have it disclosed against your will or without your consent. We also know, as I've alluded to, that trans people are disproportionately targeted by violence. And when that happens, there is little or no recourse for people in this community because they have to face what we term secondary victimization or secondary traumatization when they show up at the point of service provision, whether it's a hospital or a police station, that they will not be treated with dignity, respect, compassion, or even necessarily safety. So it's vital that when I speak to you about access to healthcare for transgender folk, we take into account even the challenges in accessing basic healthcare. And certainly I've explained to you that a lot of this discrimination comes from people directly, but we also need to not underestimate the role of systemic structures in perpetuating and inflicting acts of violence against people in this community. And what I'm talking about here are things like clinic intake forms, tick boxes that refer either to sex or gender as an M or an F, forms that ask only for a legal name and don't pay any respect to a person's name in use or a person's chosen name. I'm talking about access to facilities like restrooms. I'm talking about gender division for hospital wards for admitted patients. And we dealt with a scenario like this at I think it was either Barrow or Helen Joseph in Johannesburg recently, where there was an intense fear on the part of trans patients who are admitted in a ward that they might be subject to violence because of the ways that other patients see them. So this binary delineation that is so rampant in all of these systems is in itself not just unscientific, and hopefully at some point in the future, I'll be able to give you a 2-hour workshop on what sex and gender really are and how scientifically flawed this binary concept is. But these are intensely cis-normative and cis-centric institutions that many people who work and spend their day-to-day in the clinic or in the hospital will never notice because they haven't suffered because of it. But in understanding the needs of a community that is marginalized, it is the voices and the experience of that community that counts. And not having access to a gender-neutral restroom or not being called by the name with which you identify or being misgendered, these are not experiences that a lot of cisgender healthcare providers will ever be able to relate to, but there are significant barriers that need to be addressed when it comes to access for trans people. So that's the first point that I want to get across today. The second point that I want to get across is the concept of informed consent. So this is a bit of a departure from what I've been talking about, and I'm now speaking specifically about access to gender affirming care and how we make the decision of who gets access and who doesn't. And this is particularly important because a number of years ago, not that many that it isn't still in recent memory, the approach to healthcare for transgender people and the provision of gender affirming care was carried out on the basis of a model that is known as gatekeeping. So basically there were lists of criteria, check boxes that patients were graded against by the healthcare provider in order to determine if they could get access to care. And some of these will probably be familiar to you. You'll probably have a concept of them, whether it's an implicit concept or whether you actually studied these materials at some other point in time. But definitely in years gone by, trans people have been forced to prove the validity of their identity before we give them access to care. And this would entail things like successfully passing, which is a whole other politically fraught concept and a damaging one. But you would have to be successful in your defined gender role or in your identified gender role And this means that you would have to meet society's expectations of what it is to be a man or a woman. And of course, no provision made in that structure for the many, many people who identify outside of the binary. But we would grade you on how well society saw you as a man or as a woman, whether you could hold down a job and a home or be successful in your studies or whatever else, in order to determine that you were valid enough as a trans person to get access to treatment. If you weren't, for example, heterosexual, if you're a trans woman, but you weren't attracted to men, this would count against you. It would say your womanhood isn't valid. This, of course, stems from transphobia, but also from the deep-seated misogyny and patriarchy that still especially governs systems like the healthcare system. What this did was it disproportionately gave access to gender-affirming hormone treatment to people who already enjoyed greater degrees of privilege in the world. So if you could afford all the fancy clothes and the makeup and the laser hair removal and the waxing and whatever, if you had the resources and the ability to access this, you would be much more likely to get access to the gender-affirming care and the hormone treatment, which ironically makes part of this journey easier by easing dysphoria for the people who suffer it, by encouraging the development of physical changes that are congruent with your identified gender, et cetera, whereas people who came from a more marginalized background, who already had so many barriers in place, were less likely to pass this test. And of course, the criteria were all designed by people without any lived experience, by cisgender people looking through a microscope lens at trans people. This alludes to what Leanne was saying before me about the colonialism of data collection and how marginalized people have been used as research subjects. And they would determine what was valid and true for a trans person or not. And if you didn't meet these standards, you would be gate kept. That's where the word comes in, out of access. So we determine who was valid and who wasn't. The approach that we use today, and it's been approved or it's been advocated for by several international guidelines for a number of years now, but still these persistent myths continue to plague us, that you still have to meet this checklist, that you still have to meet the criteria, that you have to pass some real lived experience in order to get access. But the approach that we favor today is a process founded on a model of informed consent. And this is reiterated and explained in great detail, firstly in an open access journal article that I published in 2018 in the South African Journal of Bioethics and Law. And it is also promoted or advised by the South African Gender Affirming Healthcare Guidelines new document, a new journal article, also open access, that was published in the Journal of the South African HIV Clinician Society during October this year, which I encourage you all to go look at because it covers everything from institutional policies, primary healthcare, sexual health, gender affirming hormone therapy, surgical procedures, psychological or psychosocial care and support, speech therapy, etc. So this is a process of informed consent. And anyone who's been through medical school knows what informed consent is. And anyone who's been through medical school is also familiar with the 4 pillars or principles of medical ethics, which I'm going to describe for you in brief now because we don't have a lot of time. But the idea behind this is that a practice of informed consent, where your responsibility as the clinician is not to decide who gets access to gender affirming care. It is the patient's decision. They have agency, autonomy, and ownership over their body, and they get to decide what kind of medical treatment they subject that body to out of their own free will. Your role as the clinician is to give them the information that you have from your skill, from your expertise, from your research, from your training, as a doctor, as a healthcare provider, to help them to understand these are what hormones do, these are the side effects, these are the benefits, these are the risks, this is how long it takes, this is what's reversible, this is what's irreversible, and for them to make their own decision. So them making the decision is the consent, and you empowering them with that information. And we live in a day and age where a lot of trans people will have already done their own research, but we know that independent research doesn't always come from the best sources. So you do have a responsibility to make sure that they have access to the correct kind of information, that they understand it, and that if they weren't able to access the information that you provided for them, that is the informed part of informed consent, that they make their own decision. We know that gender-affirming health hormone therapy is safe. We know that it is effective in promoting the development of desirable changes. We know scientifically it's been proven that it improves the outcomes of trans patients. What I'm saying to you here is morbidity and mortality. It saves lives. It is life-saving treatment. It is not cosmetic treatment. It is not frivolous. It is not trivial. It is essential. It is life-saving medical treatment. And it is the patient's decision as to whether they go onto that treatment or not. So we're all worried about negligence and liability and being sued. And what if we make the wrong decision? What if a patient regrets it? What if we do damage to them? If the patient makes their own decision and that informed consent process is carried out properly and it's documented, and I also want to put out here that informed consent is not a singular point in time. It is a trajectory. It extends. It is the foundation of your relationship with the patient. You are absolutely covered in terms of liability. You are acting within the scope of both international and South African guidelines in a practice that is sound according to the principles of medical ethics. Beneficence, is it to the benefit of the patient? To put them on life-saving treatment, certainly it's beneficial. We contrast this with gatekeeping. Am I doing the patient a favor by withholding treatment from them? Is there a benefit from it? And there is no benefit. The second principle of medical ethics, non-maleficence, and must not do harm to you. Are there risks with hormone therapy? Certainly there are. We use these medications, as I'll still go on to talk about, in cisgender patients all the time. These are bioidentical in a lot of instances, hormones that we prescribe for postmenopausal women, for impotent cisgender men all the time. There are risks associated with it and there are irreversible changes, but they take time to develop and the risks can be managed. In a lot of instances, we even find that there are benefits from it. You know, if you're a transgender woman and you go on gender affirming hormone therapy, we cut your risk for heart disease, we cut your risk for prostate cancer, etc. And I'll contrast it again with gatekeeping. If we withhold access to life-saving care and we possibly push you even further into the depths of any coexisting mental health conditions that you have, or we make you more easily targeted by acts of violence, we worsen your dysphoria, we push you to substance abuse, parasuicide, suicide itself, or we subject you to assault, rape, and murder, which trans people do face on a daily basis. Certainly we are doing harm to you. We are contravening that principle of medical ethics. The next principle I'll talk about in brief is distributive justice. Are we being fair in the way that we allocate resources? If you have to jump through hoops and prove to us that you can succeed through a lens of arbitrary standards before you get access to care, certainly that isn't just. As I've already explained to you, it favors people who already have more access and more resources and more privilege in society, and it unfairly prejudices those who come from different backgrounds. So we can see here that by saying to everyone, you have the choice, it is up to you. You don't have to prove your validity to us, that your individual lived experience in a society, a planet populated by north of 7 billion people, each of whose identity is absolutely unique, that you don't have to fit into a box, versus that you have to meet an arbitrary of standards that we as people without the lived experience have designated for you, you can see which of those approaches fulfills the ethical requirement of justice and which one does not. And then lastly, the principle of autonomy, that a person has a right to decide. And obviously, if you as the healthcare provider are making the decision for them, you're violating that principle. Whereas if you allow them to make their own decision for themselves, you act within the principles of informed consent, you give them the information, they make a decision for themselves, and you build that relationship with your patient, you preserve that principle. So that's the second part of my discussion today, is informed consent as the preferred and in fact the only approved internationally and locally approach to offering gender affirming care, and that through a lens of medical ethics. You can read more about this in the journal article that I mentioned earlier. Lastly, I will briefly talk about hormone therapy, and the recipes for providing hormone therapy are there in the guidelines that I've discussed that have been published, that you can access immediately on the internet. It will tell you how to manage a patient from the time they come into your office, what you need to do in terms of history taking, in terms of physical exam, in terms of laboratory investigations, and how to prescribe treatment for them. And the important point that I want to get across here is that these medications are not new to us as healthcare providers. We are using the same treatments, as I said earlier, that we give to cisgender women in menopause. We are using the same treatments that we give to people who are experiencing a hypoandrogenism, cisgender men who have symptoms of hypoandrogenism. So the medications, the cornerstone for gender affirming hormone therapy for a patient assigned male at birth, this means trans women, and this means non-binary folk assigned male at birth, is estrogen. We prefer to use bioidentical estrogen where it's available. And we prefer to use estrogen that goes outside of the digestive tract, parenteral estrogen, where it's available. This means that the best approach and the safest and the most effective, and incidentally, at least in the private sector, the most cost-effective, is an estradiol, bioidentical estradiol valerate injection. If that isn't available, we can also use skin patches, Estradot skin patches, or any of the others that are available that go outside of the digestive tract. In the public sector, these medications are not available, but we do have alternatives. We do have Estrafem in most of our public sector facilities, and in many of the others, we have Premarin. Less ideal because it's not a bioidentical estrogen, it's a conjugated equine estrogen. It does carry a higher relative risk for side effects, the most significant of which is thrombosis. It does carry a higher relative risk than the other treatments I've mentioned, but the absolute risk as compared to the general population is still exceedingly low. So the medication is safe and it's effective and we should use it and we have access to it. In the cases where we're not able to give a patient high enough doses of estrogen in order to suppress their testosterone production, and this occurs predominantly with the oral treatments where we are limited by the effects of first pass metabolism. It means if I give you estrogen through your digestive tract, before it goes anywhere else to your subcutaneous tissue, to your breasts, to your butt, to your boobs, to your brain, to your skin, it goes through the liver, and some of it is metabolized to other forms of estrogen, most notably estrone. So this limits me in how high I can dose you with oral estrogen.
That's very interesting. Lucy really should consider.
Sorry, Cara, you're
Sorry.
not on mute. If I can't suppress your testosterone with estrogen alone, I have access to testosterone blockers. Depending on the facility, these anti-androgens, again, medications we're all familiar with, will either be cyproterone acetate or Androca or any of the generics, or it will be spironolactone, aldactone, Spiractin. which we use for its effect as a potassium-sparing diuretic, but it's also anti-androgenic, so we can block the testosterone. This is hormone therapy in a nutshell for transgender women using medicines that have been around, not just for years, but for decades, that are proven safe, that are effective, and that are inexpensive. The precise recipes in terms of dosages and administration, I'm not going to detail for you now because these are things that can be looked up. What you need to understand is that trans people face tremendous barriers in accessing healthcare, both basic and gender affirming. That the approach to offering gender affirming care should be based on informed consent, and that you have access to treatments that can be used in order to administer gender affirming care at even a primary healthcare level in line with our national guidelines and international guidelines, not yet in the EML, but we hope to address that at some point in the future. We still fight for that. I will speak briefly about assigned female at birth patients, and then we'll leave hopefully the next 10 minutes until 11:30 for any questions. So in terms of assigned female at birth patients, transgender men and non-binary folk, the medication that we use is testosterone. Oral testosterone is not widely available in the public sector, and we don't use it in the private sector either because it's expensive and because of its effect on first-pass metabolism. It is not safe, it is not effective, it is not ideal. Testosterone is almost exclusively delivered parenterally, either as an injection, of which there are two main kinds available in South Africa, or as skin gels. In the private sector, the options are the skin gels, androgel, testosterone undecanoate. This is a long-acting testosterone formulation. The brand name is Libido. But even in the private sector, we generally prefer to use what is available in the state, which is depot testosterone, testosterone cypionate, given as a once-a-week injection, either as an intramuscular injection or as a subcutaneous injection, which patients can learn to administer themselves. It's very easy and it's very safe. The testosterone cypionate is a potent medication, but because of its half-life, it should be dosed at a 1-week interval. When we give testosterone to patients, we do not need to give them any additional agents in order to suppress estrogen production. I'm saying this because these are things I've seen in practice. I've seen patients on a once-a-month dose of testosterone cypionate. They get an intense crash in their levels of physical energy, in their mood, in their libido. They get skin breakouts, they get breakthrough bleeding when they're dosed too infrequently. And I've seen patients who have been prescribed anti-estrogens like tamoxifen or Arimidex, medications that have significant side effects that are hugely costly and that are unnecessary. The testosterone cypionate has been available and in use for many, many years. It is very safe. We give it to cisgender men with reckless abandon for their impotence without even going into a full discussion, as we should do with every patient. We should be using a model of informed consent, whether they're cisgender, transgender, straight, gay, lesbian, doesn't matter, whether it's treatment for diabetes, high blood pressure, bronchitis, hormone therapy, etc. So the medication is there and it is available. And it's very easy to use. And I'll just reiterate to say that the specifics, so when I talk to you now, I don't think it's beneficial for me to give you the recipes because it's long and tedious and difficult to remember, and it is easily accessible. What I want to get across to you is why you should care to prescribe life-saving treatment to trans patients, and for you to understand that the provision of this is something that is within your capacity. You have both the skill and the expertise and the training and the access to the medications in order to be able to do this. And to do so through a framework that is consistent with medical ethics, which supersedes any of our personal beliefs, our religious baggage, our philosophical or political standpoints. When we step into a clinic or a hospital as healthcare providers, we undertake, in line with the pledges and the declarations and the oaths that we were all subject to at graduation, to act in the best interests of the patient through a framework of medical ethics, and to leave our personal judgments at the door. And I hope that our brief discussion today, and I would of course relish an opportunity to talk at greater length on any of these subjects in the future, but I hope that this discussion today gives you some insight into how these concepts interact, and the ethical framework through which it's centered in order to provide the treatment that is so essential and often life-saving towards a marginalized community, and to give you the understanding that you are capable of doing this in your facilities, and not just that, but that you are capable of beginning to identify the barriers, both systemic and individual, that patients face when they are when they stare down the barrel of trying to access healthcare, whether it's basic or specific, and to begin to dismantle those. So I'll thank you so much for your attendance and your participation this morning. And I hope that we can spare a few minutes for questions if there are any.
Thank you, Anastasia. Questions? Anybody? Anybody with a question? You have a question? Okay, yes.
Hi, Dr. Anastacia. So just for the room, Dr. Anastacia is also my GP. So Dr. Anastacia, you mentioned that the adoption of the new gender-affirming healthcare guidelines. What does this mean for trans persons, particularly those based in rural areas? And how will this change the face of access to gender-affirming care? Because we know that it's guidelines and not policy. So how does this actually assist the community? And like I said, particularly those that are not based in, urban settings.
Yeah, it's a great question. It's an important question. So obviously I'd love for this to be policy. Unfortunately, I'm not in a position myself, at least not at this point in my life, where I can directly influence that, because I don't sit, unfortunately, I don't sit in the DOH and I don't sit in cabinet. But we do recognize that the publication of guidelines is really the first step in a much broader discussion. And of course, on a very base level, the idea is that these guidelines are available, open access, not just to healthcare providers, but to patients, to community members, to trans people, so that when you sit in front of a clinician, you can understand whether you're being treated in a way that is fair and is in accordance with the guidelines. They are scientifically robust and they are peer reviewed. There is a profound base of evidence behind these guidelines. And the hope certainly is that since Department of Health has not up to this point been forthcoming in producing their own set of guidelines, which would ultimately inform either an SOP or a policy, that these guidelines can be used by clinicians, by lawmakers, by activists and people working in advocacy as a tool to say this is the best standard of international practice. And we have a responsibility through a lens of human rights, through so many of the principles of our country's own constitution, and all of the promises and the commitment that entities like the Department of Health have made towards bettering the state of healthcare and access for marginalized populations. Here's a tool and a starting point that we can base policy off of. So, really it's us releasing these guidelines into the hands of society in South Africa, including the activists, the policymakers, and the clinicians, and saying, use this immediately in your practice, but let's also take it forward and let's use it as a tool to negotiate with Department of Health, and then also to negotiate with medical aids to provide coverage for services, to take this to the EML committee and say, there's no reason that this shouldn't be on the formulary for primary healthcare, and to really inform that process going forward. So it is a starting point, but I think it's a significant one. I think we are in a far better position than we were before we had guidelines, because we only had access to international publications that specifically said these are geared towards Western Europe and North America, and nothing that was tailored to the experiences and the unique social and cultural contexts that exist in South Africa. And of course, we hope that this can help not just South Africa, but the rest of the region. So it's really just the birth of this process that I'm very excited to see where it goes. I can't do it by myself, so I'm also asking you all for your help with this.
Okay. Any other questions? No. Thank you, Dr.
I have a question, please,
Oh, that's a
Doctor.
question.
Dr. Anastasia, it's a pleasure to meet you. My name is Nosana Sandiazi. Kanyusile has said amazing things about you, and we've just witnessed exactly your passion. Have you written your own personal work and journey, because you're an author as well? And what is the name of that work, and where can we get hold of it?
Yeah, thank you so much for that. I have written my memoirs. I feel like I need to write another one because it was published in 2016. But the book won't die and it refuses to leave me alone. It's called Always Anastacia. I'll put this, and I don't know if you've got access to the chat box, but I'll put the name of the book in the chat box now. Always Anastacia, Transgender Life in South Africa. It is on Kindle if you're an Amazon user. It is available at South African bookstores. You can order it on Exclusive Books. You can find it in Takealot. A lot of libraries in South Africa also have copies. So that's where to find it. And thanks for the opportunity to plug my own. I'll just put it out there. I haven't made a cent on this book. I still haven't repaid the debts that the royalty advances that were extended to me by the publishers. And that's because people get a copy of the book and they pass it around, and it's great because it was never a vehicle to try and enrich myself. It was just I wanted to tell my story and to get it out there and to give people a little bit of representation. Having said which, I realized that I come from a position of privilege. I'm not the only trans author in South Africa. A colleague or fellow activist of mine, Robert Hamlin, also published his memoir earlier this year. So I'd like to plug that. And then of course, I think it's so important that it's not just white people telling their stories of being trans, because that is so much, I have to tell my own story. It's all I have. I can't pretend anything otherwise. But a book called Becoming Him by Landa Mabenge, a person of color, trans man. So I'd also just like to plug those. If you're going to read, don't just read one voice, get a diversity of experiences and pay respect to these people who have taken their own personal trauma and turned it into something positive in order to uplift the rest of their communities, and have done so of their own free will, and often at great personal cost. So thank you for that.
Thank you very much, Dr. Anastasia. I'm not sure if there's any more questions from the room.
No questions. Thank you very much, Doctor.
My pleasure to have been here. Thank you for your attention. I'm going to plug those links for the journal articles into the chat box, just so that anyone can access them after the fact. Thank you so much, and have a great rest of your Indaba.
I know you might be, you need to stretch or something. After this, the speaker, we will go for tea so that you can stretch. And please keep in mind that we need to be on time. Technology is giving us people all over the world in one room. I'm loving this. Okay.
Am I on? Can you hear me?
Yes, we can hear you.
Thank you. Thanks to Nasana for inviting me to speak with you today. My name's Cara Pearson, and I am the director of a company called Genderware SA. But before I talk about that, I just want you to understand why I'm here today. So I'm a parent of a transgender woman. She came out at 16, which was just about 5 years ago. She's turning 21 in a couple of weeks. And so I understand completely the importance about the need for gender affirming healthcare, and how important it is for people transitioning, as well as for the families who support them. When my daughter came out, obviously, as many family members and friends involved with transitioning, we were quite surprised, but love our daughter very much and wanted to support her completely. We are incredibly lucky to be living in the Western Cape and to have the gender clinic at Red Cross Hospital and Grooteschuur, where my daughter initially started. And as Anastasia was saying, this saves lives to offer this care, and it should be freely available to everyone, regardless of privilege or financial ability or color. Because I know we would be in a very different place if my daughter did not have access to that care. She struggled with her psychology. She was seeing therapists, she was seeing psychiatrists, she was on antidepressants and medications. We had no idea until she came out. And if she hadn't had access to hormones and to support groups and to endocrinologists, she would be in a very different place now. So this is incredibly important for anyone listening that would have the ability to make these services available everywhere, no matter where you are or where you live or what your financial status. I would definitely say, please, let's do what we can. I was lucky enough to be involved in a support group at Red Cross Hospital, where I met other parents who all very much would like to be supported or supportive, but found that there wasn't enough available through government or through the healthcare system for them. So I created with another parent a support group on WhatsApp called Parents of Fabulous Kids, and we have over 200, close to 200 parents, I think, on the group at the moment, all wanting to support their children 100%. And some of the things we talk about are surgery, medications, hormones, etc. And still, despite our privilege, which we definitely recognize, that is still out of the realm of possibility for us as well, because the surgeries are very expensive. It's certainly financially prohibitive, and many of the people on our group have kids that are under 18, some as young as 5, 6, 7, transitioning socially, and then teenagers that come out and aren't ready to take that step towards surgery regardless. So moving into practical items where people can present themselves as their gender and feel comfortable and with dignity. I obviously started looking into products that my daughter could wear so that she could present herself as she would like. So with another mom, I started a company called Genderware, and we create binders. We manufacture binders and are currently working on a tucking underwear for the trans girls. The binders have been available for a couple of years now, and I'm not going to say they're life-saving, but they are certainly a necessary part of most trans teens, especially wardrobe, and they were super cost prohibitive because you had to bring them in from overseas. They often didn't fit properly, so it was a waste of money. With customs duties and everything else, they were, you know, 700, 800, 900 Rand a binder, which just seemed ridiculous to us. So we started Genderware. We create binders. They're available to be fitted here at my home. Otherwise, we have a website with a page with a very specific guideline on how to fit properly. They're 100% returnable if they don't fit properly. It makes it a little bit easier within South Africa to do that. Obviously, there's no customs and the shipping issues are far cheaper. Well, my partner's since left the company, so it's just me, unfortunately. And trying to keep up with demand just from my small group has been, I mean, it's been amazing to watch it grow, because my whole business is based on word of mouth. And it was like Anastasia said about her book, I was never in this to make money. It was really to offer a product that I thought was imperative for our kids. But now I literally have a seamstress working full time on this. And even at our much lower prices than they are overseas, which range from about 200 to 275 Rand, it's still out of the realm of possibility for many people. So speaking with Tish White at the WITS Disability Rights Unit, I had initially been in contact with her about donating some binders to her program. I have since come to understand that there's an opportunity here for us to trans community about employment opportunities, because we would be quite
What's happening?
So if we could set up somebody in every, not even just major towns, but I mean, to start with, Durban and Joburg and Bloemfontein and wherever, with, you just need a sewing machine, and then we would show you either an instruction video or give you the pattern for it, possibly being able to, at some point, we're not making any money at the moment, but subsidizing the fabric even. Then we could create a situation where they're available to everybody. We're creating jobs. And so I'm speaking with Tish right now about her being the pilot project at WITS to set something like that up, but would certainly be willing.
Oh dear.
They're comfortable, they're safe, they're cost effective, and
Oh dear, Cara, we're struggling with connection, I think. I'm not sure if you can hear me, but basically you're saying you'd be open to giving us or anybody interested the pattern for them to sew it themselves, right? Have you got a video of this happening?
am I back?
Yes, you're back. Hi, yes, you're back. Do you perhaps have a video of the production line or any examples of your product?
Okay, there you are. You there? Okay, sorry, I disconnected. Okay, sorry, my
You muted.
You mute.
Please unmute. Yes. You still unmute. You still muted.
Hi.
There we go.
I'm struggling to keep that connection.
Hi, Cara.
Cara.
Hi, Cara. No problem. No, that's okay. We've heard what you have as a possible offer on the table for us to maybe get access to your pattern and an instruction video. Do you have a video that you can share with us? Perfect. Thank you so much. Thank you. Absolutely. Thank you so much, Cara. Your story is so important, and for you and so many other parents to be doing this kind of work. So we're also going to maybe try and see if we can get our parents involved and see what they can offer to us. Thank you so much. All right, thank you very much. Thanks a lot.
Okay, that was Cara. I think Anastacia will summarize a little bit of what she actually was offering with regard to the penalties and the binders. Okay. Summarize it.
Oh, all right. What Cara is saying is that she's got a seamstress. She's making binders, and she's also making panties that allow you to tuck easily. So she's willing to give away the pattern, and you can start your own business sewing your own panties and binders. So she was going to make a video of how they're made, and she was going to record it, but unfortunately she's actually got a full-time job. This is her passion. So she didn't get around to it, but she's still going to make it, and she's going to share it with us, and then we're going to watch how the production is done, and then we are going to collect from you, whoever is interested, names, and then we're going to give you access to her pattern, and then she'll give you the video, and then you're going to talk to her directly with, because like she's saying, she doesn't want to profit from this. She doesn't want you to pay her, she wants you to make money. So we're very grateful that she considering doing everything for this business. Tea time, yes.
What time is it? Okay, before you go, let's see what time is it? And 12. Please be there In 15 minutes.
And if you have your screening, you must also screen.
Okay, please be back at the beginning of the 10 past. At 10 past 12.